think what patients don't realize is the humanity behind medicine. In order to be treated for cancer, your cancer must be diagnosed by a pathologist. It must be a tissue diagnosis. When you send a biopsy to a pathologist, that's not sending a biopsy to a box where you're going to spit out an answer. It's about a consultation.
Hi, Pauline. How are you doing?
Hello, Ify. Very nice to see you.
Okay, awesome. Now, I am so lucky to be here with Dr. Pauline Alakija. And I'm going to first of all start off with a bio to introduce her. Dr. Pauline Alakija is a trailblazer in Canadian medicine. She is known for her courage to stand up for fairness for physicians and patients. She is often the first to raise issues of equity in her medical workplaces, universities, associations, and organizations. She is a surgical pathologist at Alberta Health Services, where she has a special interest in breast pathology. She's also a forensic pathologist and works at the Office of the Chief Medical Examiner, where she does locums as a medical examiner. With a master's education in medical education, she teaches at both University of Calgary and University of Alberta, where she is a clinical professor. Dr. Alakija has had many firsts in her career, several considered successful and some not. One of the measures of a great leader is how they react to and continue on in the face of apparent failure. Notably, even an unsuccessful first can pave the way for other leaders. Some of Dr. Alakija's distinctions include being one of a small number of physicians in Alberta to serve on both the Alberta Medical Association Board and the College of Physicians and Surgeons of Alberta Council, receiving the NATO Medal for Peace and Freedom for forensic work performed in Kosovo, serving as the president of the Alberta Medical Association section of lab physicians, being one of a few women named to the AMA negotiating committee, and founding several advocacy organizations. Dr. Alakija has held many leadership positions during her career. However, the leadership she's most known for is for her informal leadership. Dr. Alakija believes that leadership is most needed when the job is not remunerated or formalized. When a gap or a need has been identified, she has stepped up multiple times to advocate, collaborate, strategize, and lead. Dr. Alakija is unwavering in her support for other leaders, especially women and women of color, and is a strong advocate and mentor for all high potential leaders. So welcome, Dr. Alakija.
Thank you. That was a very nice introduction.
Well, it's well deserved, and there's some things in there that are just really incredible. So I want to first of all say thank you for what it says there about your unwavering support for women, women of color. You know, that means a lot to me, and I've been a recipient of that support. So I thank you
Good.
very much. Okay.
How do you feel that?
Yeah, I very much do. Now, I always start off by asking what a name means. Okay. And I think for you, a lot of people might be surprised, myself included, when you look at the name Alakija, at first you would think Alakia, Spanish, right? But I know it's an African name, correct?
That's correct.
Okay. So do you mind telling us what that means?
So it is a Nigerian name. The origin is Yoruba. It's a very long story on how my dad got that name. My dad's father was a medical student in Glasgow. He was from Nigeria, and my father was born in Glasgow. And the Alakija family is quite big, many from Nigeria, the United States, Canada. I believe a lot of the family is also in Brazil, and there are many doctors and lawyers and engineers. I think there are many engineers in the Alakija family. Yes, that's where I got my name. I know I don't look Nigerian, but I can tell you I am.
You're my Nigerian sister for sure. Awesome. Okay, I love that. It's good to know, and I like I said, I think a lot of people might be surprised by that. So it's not Alakia, it's Alakija.
Mm-hmm.
Now, I want to ask you, what is pathology, and how does one become a pathologist? How do you become a pathologist?
So, to become a pathologist, you have to be a physician first. Very interesting. One time when I was negotiating for pathologists, and I won't say what health authority or whatever it was, I don't want to embarrass anyone, but sometimes people who are not physicians don't realize that pathologists are physicians. right? We are lab physicians. We do as much training as radiologists or surgeons or internists or cardiologists or anyone who's a specialist in medicine. So usually 4 years of undergrad, 4 years of medical school, 5 years of residency, and then many of us go on to do fellowships. I have a fellowship in forensic pathology. I also have extra training in breast pathology and cardiac pathology, and I also have a master's degree in medical education.
Yeah.
So that not many pathologists have that though. That's a little bit unusual about me, but yeah, it's a long time to become a pathologist. Very intensive work. As you know, you're a radiologist and you went through something similar.
Yeah. Yeah, for sure. I'm so glad you said that because pathologists are such an integral part of the breast cancer diagnosis and treating team. And it's amazing how many people do not understand what you guys do, which is one of the reasons why I want to highlight this. It's a lot of years. You guys are physicians. And when I see patients, I diagnose them and they say, "What do you think?" Well, what I think is that from experience, it may look a certain way, but the ultimate diagnosis is going to be given by the pathologist. That's how important you guys are, and I know that many people do not know that.
That's right. In order to be treated for cancer, your cancer must be diagnosed by a pathologist. It must be a tissue diagnosis. Yeah, that's very important because there are a lot of things that could look like cancer and they're not cancer. There may be infections or there may
Hmm.
be an inflammatory disease. And that's why you actually have to have the tissue and diagnose cancer under the microscope.
Yeah, exactly. And when we do the tumor boards, you guys are very much a part of that as well.
Yes,
So yeah,
absolutely.
yeah. So how long have you been practicing?
Oh, a long time. So I've been a physician since 1990, and I've been a pathologist since 1997.
Oh, okay. I
Yes.
was not aware of that. Did
Yeah.
you start off in
Uh,
family?
for for a few years, I practiced as a family doctor. Also, while I was a family doctor, I spent a lot of time in the operating room where I was a surgical assistant for many general surgeons and orthopedic surgeons, and I love my surgery colleagues.
Mm.
Um,
Interesting. I
yeah.
did not know that. See? Okay. I'm learning more and more about you. And so I want to know what drew you to breast pathology?
Well, I think there was a need for that expertise. When I first moved to Edmonton, I was actually a cardiac pathologist, but my job was at Dynalife. And sometimes hospital administrators also don't understand the expertise that pathologists have, and they think we're ubiquitous and can do every kind of pathology. So it was deemed that heart biopsies were only done at the university hospital and that breast biopsies were given to Dynalife. So I had to work to get that expertise. I took a lot of looking at a lot of breast biopsies. I also teach other pathologists to become breast pathologists. But like anything in medicine, everything is getting more and more complicated and more specialized.
Mm-hmm. I know you've come to my rescue. When I look at pathology results, sometimes I'm like, hmm. And then I know I can call you because you will know.
Absolutely. I'm
Yeah.
always happy to talk to my surgery and my radiology colleagues.
Yeah, for
And
sure.
that's part of being a pathologist. And that's why we are physicians, so that we understand what impact we have on a patient. And we don't just look at the tissue under a microscope. It's also a context, right? We have to know what the radiology looks like. We have to know what signs and symptoms that patient has. That's why it's really, really important when you send a biopsy to a pathologist, that's not sending a biopsy to a box where you're going to spit out an answer. It's
Right.
about a consultation. That is
Mm-hmm.
always done in the context of, well, what does the patient need? Um, what does the radiology show? Um, and it's really important to have the whole picture of the patient.
Right.
And I think we are so specialized and subspecialized now that we forget that. The
Yeah.
patient is at the center. We're just so busy doing our own jobs. It has to be in context. Physicians have to look at the history, the physical, uh, what's needed for the outcome, right?
Yeah. I was going to talk about that later, but we'll touch on it now because I think from listening to you at some of the conferences that you've come to, some of the radiology conferences, there, it does help when you get a lot of information to help
Absolutely.
you with a diagnosis, right?
That's right. For example, there are certain tumors that if I see a little bit of a biopsy of a certain type of tumor, and the one I'm going to talk about is a fibroepithelial lesion, you will know what that means, right? We
Mm-hmm.
sometimes talk about fibroadenomas. Maybe that's what people will know them as. If I get a biopsy of a fibroadenoma, and it's a 1 centimeter or 2 centimeter biopsy, and it's in a woman who's 50, it's a fibroadenoma. However,
Mm-hmm.
if all of a sudden I got the history that it was a 12 centimeter lesion in a 30-year-old patient, I'm not, even though it looks exactly like a fibroadenoma under the microscope, it may not be, right?
Mm-hmm.
A 13 centimeter lesion or a huge lesion in a 30-year-old woman, it's probably not a fibroadenoma. That patient needs more done. Maybe part of her tumor looks like a fibroadenoma, but I'm willing to say that probably that tumor is something else,
Yeah.
something more
Interesting.
sinister.
Yeah. I try and put as much as I can. And like you said, as we over the years, things are getting more and more complex,
Right,
practicing for so many years, but I'm seeing some new things still, which is kind of crazy.
right,
Yeah.
right.
Okay. I don't know if you remember when we met, hey?
I remember it was actually on the phone. Well,
In
um,
person.
it was at a radiology pathology meeting, I thought.
Yeah, it was a journal club, right? And I
Right.
remember somebody saying something about pathologists and some basement, comment like that. And then you chimed up and said something, and I thought, oh, I like that woman. I didn't even know who you were, but I'm like, I just thought, yeah, you're awesome. So what is one of the biggest misconceptions about pathologists?
I think I've actually touched on that.
Yeah,
So
you
when you
have.
send a couple of cells or a sample biopsy to a pathologist, it just goes, no matter what context it's from, no matter male, female, young, old, that we're going to spit out the right answer. But it's not like that. There's much more subjectivity. It's subjective and objective, right? It's
Yeah.
you have to have the context. A tumor that looks like it is benign in a female may be malignant in a male. A tumor that
Mm,
looks like it is benign in a 2-year-old was probably going to be malignant in a 25-year-old, right? So
yeah.
we need context about the patient.
Yeah.
And remember, the example I gave about the fibroadenoma, you're only giving us a sample. You're not giving us the whole tumor.
Right.
That's why we have that. We need to know the additional information. We need
Yeah.
to know, are we getting a good sample of that tumor or just a tiny sample of that tumor?
Yeah.
And we
Yeah.
need to know how the patient's doing, right?
Yeah. I asked that question intentionally because I do know that there are a lot of places where it's the technologist that writes the information on the pathology sheet and the radiologists don't look at it.
Well, that's very interesting because if you look at the standards of practice from the College of Physicians and Surgeons of Alberta, and if you look at any like common sense, that history should come from the physician. And it is the
Mhm.
physician who is responsible for it. And if there is no history, or if the history is misleading or inaccurate, it is that physician who's responsible.
Right. Okay.
It's not, and it's just, why are we here? We're here
It
for
makes sense.
patient care. We want the
Exactly.
best for the patient. If you want the best for the patient, then the person who's the most qualified should be communicating.
Putting that on. Yeah, I completely agree. And in the era now where we have this my Alberta ID, right, where patients can see their results,
Right.
can patients see their pathology results on there? I get asked that question, and mm,
Absolutely.
oh,
And so I do communicate. as much as possible as I can with my family practice colleagues and my surgery and radiology colleagues. And family practitioners right now are frustrated because pathologists can write the report and sign it
Mm-hmm.
out at any time. I could be doing it at 6 a.m. or 4 a.m. or 8 p.m. at night. We're so busy that
Right.
it could be any time during the day where we press that button and say, my report is finalized. And it goes on to Connect Care and Net Care and to My Alberta patient portal.
Mm-hmm.
And the patient has access to that report right away. Unfortunately, we're still in an age, and you'll know this in radiology as well, we're still in an age where we do our reports in medical jargon,
Yeah.
right? We don't write our reports to explain them to a patient. There
Yeah.
are some places in pathology that are changing that, but in order to be accurate, we have to write them in medical jargon.
Yeah.
Unfortunately, sometimes the medical jargon can be misinterpreted by a patient. If a patient looks at that report without their family doctor or surgeon looking at that report with them. So it's very frustrating right now for many doctors
For sure.
who and just think the process to get even just a breast biopsy. The process is that the family doctor needs to have the patient get a mammogram. They might also need an ultrasound, might also need an MRI or other imaging techniques. You
Mm-hmm.
find some calcifications or a lump of some type, and then that patient has to go back again to radiology, to a radiologist who actually can do the biopsy, because not all
Mm-hmm.
radiologists who do imaging do the
Right.
biopsy. So you got to go to a specialized radiologist that does the biopsy. That
Mm-hmm.
biopsy gets sent to a pathologist. The pathologist may take quite a bit of time with a biopsy because, I mean, I'm not saying 3 months. It won't be
Yeah.
3 months, but what I do is I triage the breast biopsies first, and I always do them first
Oh,
because
good.
I know there's a high incidence of breast biopsies being something that might be malignant. And if it's a malignancy, it's going to change that woman's life forever.
Right.
And then even before I get the breast biopsy, it needs to be processed in such a way that I can look at it under a microscope. You don't just take the tissue and put it under the microscope. It needs to be processed in formalin and all sorts of different chemicals, and then dyed with certain inks and dyes so that I can actually look at it properly. And
Mm-hmm.
then once I look at it, I don't always know exactly what the answer is, right? I sometimes have to show it to colleagues. I have to sometimes stain it with different stains to make sure I know what's exactly on that slide. Is it an in situ carcinoma, or is it an invasive carcinoma? Is it a lobular carcinoma or a ductal carcinoma? Because those are so important for
Mm-hmm.
uh, determining what happens next to the patient in terms of prognosis, in terms of treatment. So now that report goes on, and a patient sees that report without the guidance of a doctor. And I don't always know what type of patient that is. Is it a patient who's going to understand that, or a patient that's not
Yeah.
going to understand that report? So it is a little bit of a problem sometimes. I'm not saying that it's a problem that patients get their reports. I think we have been too paternalistic in medicine for long enough that the doctor knows best, and the patient doesn't see everything in their record. They should see everything in their record. I'm all for disclosure, I'm all for transparency, but it does need to be explained to them in a way that they can understand.
Yeah, I agree, and that's kind of where I struggle too. You talk about people seeing their pathology result and not being able to make sense of it. We see the same thing too. With the BIRADS 5, we've worked hard so that if we think it's a BIRADS 5, meaning it's likely a cancer,
Right,
we push it along, right, to go to the comprehensive breast care program or the
right,
Calgary breast health program. And there's
right,
a little blurb that we put there, the macro 5, which says, in essence, even if this comes back as negative, we are going to ask for it to be taken out because it's
right,
discordant, right?
right, right, right.
And there are several patients that come in for that biopsy and they've not talked to their family physician. So they're coming in like, oh my gosh, what is this? And so we end up being the ones that have to explain, what it is. So it's good and bad in some ways. I try to tell patients, don't Google, try and make an appointment with your family doctor right
Right.
away so
No,
they can
I
discuss it.
I'm gonna disagree with you just a little bit. We usually agree
Okay.
on things. I think that if you tell people not to Google, it's not gonna work. We get all so much information from the internet. I think the best thing to do with a patient is to say, "Look, these are safe sites to Google." Right? Like,
Fair,
what look
fair.
at the site from the Mayo Clinic. The Mayo Clinic has fantastic information. Cleveland Clinic has fantastic information. There's a website, in Canada, and I'm sorry, I should know. I think it's called My Path, My Pathology.
Yes.
I think that patients should Google that.
I will put that in the link. Yeah, you're absolutely right. There
Absolutely.
are safe spots that they could Google, but oftentimes that's not what happens.
When we say don't Google, we're doing them a disservice, right? Because they're going to Google anyways. Their friends are going to Google it. We need to direct them to say, look, these are the sites that are going to give you the accurate information.
I like that. That's a different way of thinking about it. Yeah, for sure. Um,
Because otherwise, they're going to Google and they're going to get the sites that say, oh, you need to be treated with ivermectin, right?
yeah,
Like, just horrible that those
yeah,
exist.
yeah. No,
Yeah.
I completely agree. So yeah, no, we will agree on that.
Yeah. Yes.
And I
But
like
if we
to
do agree on it, I think we just sort of saying, well, how
different
can
way.
we manage it? There's so
Yeah,
like in a perfect world, it would be best that they don't look at a computer and then come with you with to you with an open mind. But how it is that when a patients go to see physicians, they're not going to remember everything you say to them. So they
for
need
sure.
do need somewhere to go, the internet or something written that says this is what you have and this is what it
When I
means.
think of it in terms of that Googling, I think more of, for example, there's so many patients that come and they've Googled what a breast biopsy is like and it hurts and it's great. And when I'm done, they're like, oh my God, I was stressing about that. That's what I was stressing about. Like, what a shame. So you Google and some have a bad experience and they'll talk to people and they're like, oh my gosh, this is not what I was expecting and it's great. So, but yeah, you're right. A safe site to go to is good. I like too that you mentioned triaging, because we do have obviously the anxiety level for breast is high and patients come in like, how long is it going to be? And what we say, I mean, correct me if I'm wrong, we usually say about 7 to 10 days. And I think
Right.
that's generally what happens, right? And I would think that, based on what we write on the sheet, if it's something that needs to be rushed, that you guys do triage accordingly,
Right.
right?
Right.
Yeah. Yeah. Okay, good. Okay.
And
So,
and you know what? That's again, that's part of being a physician and
mhm,
being a professional, right?
right. Yeah.
Is that we know what things need to be rushed, right?
Yeah.
Because if you have that foundation in medicine and you know as a physician, these are the things that impact a patient physically or emotionally, or patients that need a diagnosis quickly so that they can get to an oncologist, or certain diagnoses have certain impacts that are more than others, then we are going to triage those biopsies
Hmm.
in a certain way.
Okay.
And I think that's important because, again, it's not just a black box where
Yeah.
biopsy goes in there and it's first come, first serve. It
Hmm.
is looked at by professionals that say, you know what? That biopsy is going to have such an impact, no matter what the diagnosis is. That
Hmm.
will have such an impact on that patient's life. We need to do that first.
Yeah. Okay. I'm glad you said that because let me ask you, when we put stat on a BioRads 5, does it change timing of when we get the
I
results back?
um Probably not. If it
Mm,
comes to me, probably not because I'm doing the breast biopsies first anyways. And
okay.
there's always a downfall of doing stat. and I'm going to give you a story of when I was a young pathologist.
Mm-hmm.
If you rush a pathologist too much
Mm-hmm.
and they don't do all the stains they need to do or show other pathologists when they need to, you may get a wrong diagnosis. If you get interrupted in your workflow,
Mm-hmm.
you're more likely to make a mistake,
100%. Yeah.
right? If
Mm-hmm.
you have a certain workflow and that's disrupted by someone saying, oh, you need to do this first and you need to do it fast within a day, and you don't take the maybe 2 days that you should have to do
Mm-hmm.
everything that's needed, you definitely could make a mistake,
Well, that's good to know, to convey that to patients, right? Because
right?
they want the
I
best.
I'm not sure that well, I mean, it depend everyone has their workflow in a different way, and
Mm-hmm.
there may be pathologists that don't triage their cases, but I can tell you the vast majority of us would triage our
Would
cases.
do. Okay.
Yeah,
Well,
and
that's
if
good.
you see BI-RADS 5, I don't think there even should be a necessity to ask for that stat because I think most, I'm not saying all, but I'm saying most pathologists would do that as fast as they can. That would go to the top of their work list.
Okay. Well, that is good to know. Okay. Cool.
But you need to put BI-RADS 5 on the history because
We have
there
to.
are many, actually, there are many radiologists who do not. I
Really.
get histories all the time that I know when I go and look at the radiology that it was a BI-RADS 5 and that is not mentioned anywhere in the history. I also get
Mm,
many, many fiber epithelial lesions where there is no mention of what the size of the lesion is. It
mm.
happens all the time.
You're right. And
Every radiologist, just like every pathologist, has a different way of doing things.
well, it shouldn't be. We should put the measurements. If I do a mass, I'm going to put the measurements. If it's calcifications, I'm going to put the measurements. If it's a BI-RADS 5, we should put that on the sheet
Yes,
so
I
that it
agree.
triggers that,
I
call
agree.
to the CB. So if it's not happening, it should happen. It's
Yes.
an oversight, right? So, okay, so I'm glad we talked about that. Along those same lines, I know the physicians that mentored me, they always used a 14 gauge.
Okay.
And working in different places now, I see people use smaller and smaller needles, 16, 18 gauge, because they think it's more comfortable for the patient. What are your thoughts on that?
So it's not about doing a really small gauge and getting lots of tissue. It's the contiguous tissue that helps us, right? The architecture of something. It's not just the cells we're looking at. We're looking how the cells interact with each other and how they interact with the stroma and what kind of pattern those cells make in the tissue. So the biggest contiguous piece of tissue you can get for us, the better. Now, am I saying you need to do a 10 gauge every time? No, you don't. 14 gauge is quite adequate. We have enough tissue to do our stains. We have enough tissue to do deeper sections. We have enough tissue to do our breast biomarkers, usually, right? You
Hmm.
can't always say if you get a little corner of a tumor, it's very difficult to work with, but
Hmm.
14 gauge is very good. You're right. When you get smaller than that, it does become difficult. And it's not just for us. As you know, working with tissue tends to dry out. We live in Alberta,
Hmm.
and the smaller you get a little string of tissue, it could dry out and it could absolutely ruin the tissue that we're looking at down the
Hmm.
microscope. I don't know of any evidence that says that doing a 16 or 18 gauge is better for the patient, is it? Like, you would have to tell me.
Honestly, no, because once a patient is frozen, I mean, think about it. When we do stereo biopsies, we're using bigger needles, like 9 gauge, 10 gauge, and we put enough freezing in there that why risk using a smaller needle and missing the diagnosis or changing things for you guys when you can use a 14 gauge?
Right,
I think the maximum I've ever taken is 5. And if I take 5, it's probably because, when I've looked at the sample, it's maybe fragmented or I didn't get as much.
right,
But usually 4,
right.
because I know, at least I've been taught, that you do need that extra piece for biomarkers.
Well, we do biomarkers on the best piece, right? So it's not
Okay.
about the number of pieces you take, it's about the
Mhm.
best piece of tumor that you
Okay.
take. So
Yeah. So, but I have seen people take 10 pieces, and like, Wow, it's a bit excessive, but I'm glad you mentioned.
Well,
I mean,
interesting,
yeah.
because it depends why you're doing it. So I think, again, part of being a physician and part of having that professional judgment, I'm not going to say that every patient has to have a 14 gauge. Do I like 14 gauge? Absolutely. Have I made good diagnoses on 16 or 18 gauge? I have. Has it been sometimes difficult? Yes. Is it more difficult than a 14 gauge? Absolutely, it is. Is it possible that I might not have enough tissue to get biomarkers? That's possible. However, there might be instances where you want to use a 16 or an 18 gauge. It's a tumor that you have very good aim for. You know you're going to get the tumor, you know you're going to get enough cells, and maybe the lady is on, I don't know, maybe you're worried about bleeding,
Blood thinners or
blood
yeah.
thinners or something
Yeah.
like that. So there might be some cases, but do I think that people should routinely do their biopsies using 16 or 18? I don't. It really makes it difficult for the pathologist. And I always think, well, what would I like as a patient? What would I like if that was my mother?
Mm-hmm.
What would I think if that was my sister, my best friend getting a biopsy? I would rather them get one biopsy and get an accurate diagnosis
Right.
rather than having to maybe get two biopsies
Right.
or maybe even getting the wrong diagnosis. I mean,
Absolutely.
so I'll give you an example. If a patient's got ductal carcinoma in situ,
Mm-hmm.
you are you're way more likely to get that little focus of invasive carcinoma if you do the 14 gauge than if you do a 16 or 18 gauge, right?
Okay.
It's all
Well,
on what's best for the patient. And
right.
sometimes what's best for the patient is using a smaller needle. I can see that that might be in some instances, but for routine, for me, I think if I was the patient, I would like the 14 gauge if there's no difference in the freezing.
Yeah. No, I routinely use 14 because for that reason, and maybe with some notes sometimes because we're in the axilla, lots of blood vessels around. I might use 16 for a lymph node,
Right.
just to be able, yeah, but otherwise, I stick to 14, which is, yeah, I think that's the best way for the reasons you gave, you know.
Okay.
What is RADPAT concordance?
Yes. So the concordance between radiology and pathology. Well, again, you know how difficult it is to put a needle into a breast. A breast is a mostly fat, right?
Hmm.
And it's very mobile and it doesn't have structure like a kidney or a liver or something like that. So it's very difficult to be accurate, right? So
Hmm.
for many reasons, that needle may get the tumor or may get the capsule beside the tumor or may not get the tumor at all or may get a part of the tumor that isn't so diagnostic of the rest of the tumor. So therefore, when you look at the radiology and the pathology, if the radiologist says, "Oh, I think that lesion looks malignant," and the
Hmm.
pathologist comes up with a diagnosis that's no, they didn't find
Yeah.
malignancy in the biopsy. Well, that means you can't stop. That
Right.
means you have to investigate why the two professionals thought something different, and the other way around too.
Yeah.
If the radiologist said, "I'm sure that lesion is benign, but I'm going to biopsy it anyways," and it comes back as malignancy, you got to say, "Wait a minute, what happened here?" There,
Hmm.
there are some malignancies that can absolutely mimic benign entities in radiology. That does happen. But other things do happen too. Like, biopsies can be mislabeled with the wrong patient's name, right? I
Yeah.
mean, that would be a
Unfortunately, well,
disaster. That would be a
yes.
disaster. That's one of our worst disasters. But I think when you think, I mean, that's probably the worst case
Worst
scenario
case scenario.
when
That
radiology pathology does not
match.
agree. But I
Mm.
think the most common scenario is that maybe the pathologist didn't see something in the biopsy and maybe needs to go back and look at it again. Or
Hmm.
maybe the needle didn't quite get that malignant looking thing that you saw on on your radiology.
Yeah.
So
I
it's
say this.
sampling error or interpretation error. There's all sorts of different types of errors that can be made.
Yeah, because sometimes, yeah, there are very few instances where I would disagree, and then it's a matter of, okay, do they go to surgery and get it taken out, or do I repeat the biopsy? And if I repeat it, it's going to be a larger needle, you know,
Right. Right.
like a 10 gauge, just to make sense of what's happening. And I do remember I've only had one case in my entire career where I thought it was a malignancy. Pathologist said no. I said, I think so. Look again. He said it's not. I said, I really think so. And the third time, I think I actually sent it to you,
Okay.
and it was.
Ah,
So
okay.
yeah, yeah.
Okay.
So that's a bit unusual, I would say. But I mean, point being that we work collaboratively together to get that diagnosis
Right.
out. It's really a team effort, right?
Yep.
And again, the
Yep.
critical, just emphasizing the critical role that you guys play in the diagnosis. Because if I could have just left it too, and said it's fine, but you guys usually help us with
No,
that
when
diagnosis
there's that discordance, I think you have to have that conversation.
for sure.
I think you have to have that conversation with the pathologist. It is way better to go back to the pathologist who originally looked at the biopsy, and then maybe they can go, "Oh, I didn't know that history, right? I didn't
Hmm.
know that. Let me look at it again."
Yeah, and I think surprisingly, there are a few physicians that don't know that they can call you guys and talk to you.
Yes.
You know?
And it needs to happen. They should be calling us. If it
Yeah,
doesn't make sense, you should be calling us. Like I
yeah.
said, there are so many places where something could happen to that tissue or biopsy.
Right. Yeah. Now, from the time you started practice to now,
Mhm.
what's changed the most? Because there's definitely been change. I mean, there's got to be change, right? So, what's changed the most, like in terms of, I don't know,
Can
advances
I
in
pick
pathology?
2 things?
Absolutely.
Because one is going to be I'm gonna talk about the specifics of the job, and
Okay.
2 is I'm gonna talk about what makes the job more difficult for us now.
Okay.
So the specifics of the job and things that are actually really exciting is the explosion of different things you can do to look at a cancer, to classify it, and I guess the word would be personalize it.
Okay.
Okay, so right now, when we look at a breast biopsy, we look at it histologically and we classify whether it's in situ, whether it's invasive, whether it's lobular, whether it's ductal. And I say lobular and ductal because those are the two most common types. But as you know, there are probably 20 different
There are
types.
others. Yeah.
And the first thing we think about is it even breast cancer? Maybe
Mm-hmm.
it's metastatic cancer from the person's lung. Maybe
Mm-hmm.
it's TB, right?
Mm-hmm.
Like,
Yeah.
is it even a cancer?
Lymphoma,
Is it
who knows?
Yeah,
Yeah.
all these different things that it could be. But then once we determine it's a breast cancer, it's amazing all the different things we can do to profile that breast cancer. Does it have estrogen receptors? Does it have progesterone receptors? Because that will determine whether you treat that patient with anti-estrogen or anti-progesterone. Is it a HER2 tumor?
Mm-hmm.
Because that completely puts them on a different treatment path.
Right.
Something that we never used to do, something called a Ki-67, which is labeling the cells to see, are the cells going to proliferate or not? So basically, what that means, if you have a lot of proliferating cells in a tumor, that means it's growing very fast. And
Okay.
that also determines what kind of treatment and prognosis they should have. But what we're not doing yet, and what is happening in some places,
Mm-hmm.
is that you can take a cancer and you can use maybe 20 or 30 different stains or genetic type profiles to determine if certain types of personalized cancer therapies may work on that cancer or not.
Okay.
And that's
So,
what's coming. So when I first learned how to do pathology, and then, we sort of joke a little bit and oversimplify it, is it cancer? Yes or no?
mm-hmm.
Well, now, is it cancer? But we actually need to use a synoptic form because there's maybe, 20, 30, or maybe even 100 different things that we need to look at under the microscope, or stains that we need to do to give the oncologist information about that particular tumor. So when I started pathology, we did not use synoptics because there were maybe 3 or 4 different things we had to say about
Right.
that tumor. Now there are, like I said, 20 or 30 different
Yeah.
things we have to analyze in every tumor we look at.
Yeah, I find that so interesting. So, do you think it's going to be a situation where we give you the sample and you are going to tell us everything, or is this something that the oncologist is going to have to push for
It's
after
both.
you give? Okay.
It's going to be both. There are some. So that brings me to the part that makes our job really difficult.
Okay.
Some people will say, well, we only have so much money, right? So for breast cancer, I automatically get a breast tumor profile where I get the estrogen, progesterone, HER2. It's automatic in every single breast cancer I see. Or
Yes.
for other kinds of cancer I look at, so for example, melanoma of the skin, I don't automatically get a, a sort of genetic or cancer profile done on those tumors.
Okay.
The patient needs to see the oncologist. And if the oncologist says, well, this is maybe not the type of patient that is even going to get that kind of treatment, I'm not going to ask for a cancer profile done on this tumor. And for another type of patient, maybe they're young and they don't have heart problems and they don't have contraindications to getting some very toxic type of chemotherapy or radiation
Mm-hmm.
therapy, or whatever you use, maybe they will ask for a cancer profile to be done on that tumor because some of those profiles take thousands of dollars. And
Mm.
if you're not going to treat a patient anyways, then why would you ask for that cancer profile
Fair.
of thousands of dollars to be done?
Right. Right. That's interesting. Okay.
Right? And you need
So,
to talk to the patient. You need to see if their body can handle the treatment and if they, as a person, as a patient, even want the treatment.
right. So I think I'm hearing that the difficulty is in the triage of who gets it and
Right.
do they want it? Like, is it going to make a difference?
Right.
And then I guess what plays into it is age, as
That will
well.
too. And
Right. And what a patient wants, really, what
right.
a patient wants
Right.
for, okay.
So for
That's
breast tumors,
right.
even if the patient is 95 years old and
Hmm.
they have a breast cancer, and they may say to their doctor, look, I'm not going to have chemotherapy or radiation therapy, we still do the profile because it's
What profile?
determined.
Like, you mean the
ER,
estrogen,
ER, PR, HER2.
HER2?
Yeah,
Right. Standard. You do that on everybody.
yeah,
Right.
it's standard. We do it on everyone, and the Alberta bureaucracy has decided it's better just to do this profile on everyone and then it be
Hmm.
done quickly rather than waiting for a profile to be done after the oncologist sees the patient. So I'm going to talk about the thing that makes medicine very difficult right now. And I think that probably radiologists, pathologists, family doctors, surgeons can all agree is that many decisions aren't made by physicians anymore,
Yeah.
physicians with their patients.
Yeah.
And it's the bureau- bureaucratization of medicine.
Yeah. Which is
Now, I
sad.
understand why it's happened. We only have so much money. I'm not
Hmm.
sure always the right decisions are made by people who are not physicians. They're doing the
Right.
best they can, but it's very frustrating as a physician. So, and and it can be simple things. So, for example, today in this podcast, I could be at work, right? I could have gone to work this morning and done many things for patients, but I
Hmm.
couldn't because I knew I couldn't do this podcast at my work office on
Hmm.
my computer because
No
My
problem.
bosses in Alberta Health Services say that I can't use Chrome on my
Hmm.
computer.
Yeah.
Really?
It's, yeah, pretty sad.
That's
Yeah.
that's really disappointing, and I can tell you
Yeah.
there are many things in medicine that you can only use Chrome for. So,
Hmm.
I'm limited in what I can do in my workspace because
Yeah.
of someone who doesn't understand what I do. There was a blanket decision that no one is allowed to use Chrome browser unless they need to. Well, you know what? I'm a pathologist. I'm at my computer 8 hours a day.
Mm-hmm.
I use visuals, right? Just the same as a radiologist. I need to use different browsers sometimes for different educational purposes.
Yeah.
And
No.
it's really sad that me as a physician, that decision, blanket decision, was just made for me without consulting me.
Yeah. No, you're right. There are a lot of decisions made, and unfortunately, our hands are tied. But I will also say that there are decisions that are made that are by physicians, which, and I refer example as an example to the Canadian breast screening guidelines.
Right.
Those are
We
made
both know.
right, and this is a problem, right? So there are decisions that non-physicians make that impact us, and there are decisions that physicians make that impact us, and it just blows my mind. But yeah, I hear you. And along those lines, because of that disparity of breast cancer in racialized women, and especially like with Black women, how the incidence is lower in white women, in Black women, but the mortality is way higher.
Mhm.
Is there anything that you see pathologically now, or that you anticipate to see in the future, that will help us understand why this is going on? Because this is real and it's a problem.
Oh, no, the why is a bigger question than I can
Hmm.
answer. I can say it is happening, right? And you
Yeah.
can say as a radiologist it is happening. There's many things that we know on the ground. Like, for example, we knew during COVID that there were
Yeah.
many people who should be screened and weren't being screened. And as soon as the floodgates opened after COVID, we saw tumors that were pretty bad.
Yeah.
I mean, you always see bad tumors, people who are in
Yeah.
denial, people who didn't get to their screening, people who, for some reason or other, the tumor became very big. But there
Yeah.
was more of them right after COVID.
Yeah, for
And
sure, because we
right,
stopped screening, right? And
right,
it's just an example of the impact of when you stop screening, here's what happens.
right.
And we saw it, for real. Yeah, for sure. We're getting to the end here. I want to touch on a few things. Papillomas. You just recently told us about the change, which so timely, because I literally the day before was having a conversation with a patient about a papilloma, right? And I just, if you don't mind, just kind of mentioning, because I bet you not a lot of radiologists know about this change.
So papillary lesions are little introduct growths that are usually benign. A few years ago, there was a very convincing paper that said, these papillary lesions, or some of them are papillomas, some of them could be cancer, right?
Hmm.
Papillary lesions seen in a biopsy. If you're doing very small sampling of a papillary lesion, say with an 18 gauge or 20 gauge, or who knows how small you can go, the
Hmm.
smaller you're sampling, the more likely that that lesion may have something malignant elsewhere in the lesion, right? If you sample it on a vacuum assisted biopsy and it's, 10 gauge and you've
Right.
probably gotten the whole lesion, that's
It's
been
great.
pretty good. We've
Hmm.
we've seen it. We think it's okay. So a while ago, a paper came out saying that if you're only sampling a little bit of these papillary lesions, you have to go back and remove them because up to 10 or even 20% of them may harbor some atypical or even malignant cells in these papillary lesions. And that may have been true for the size of papillary lesions or the patient population that was looked at in that study. But what we've found after now it's been 10 or 15 years or more of us taking out all of these small papillary lesions is that very few of them actually have malignancy in them, and that most of them can be watched. And there's a lot of common sense that goes into this, right? If
Hmm.
it's a really big lesion,
Of
and you've
course.
taken a very small sample of it, well, you're taking more risk. If it's a
Right.
small lesion and you've taken a big sample of it, well, the risk is very low.
Yeah, no, thank you for that. I just wanted people to hear that because that's been, I remember, I'm sure you know who Dr. Daniluk, John Daniluk was, and I remember talking to him about papillary lesions, and it's always been a thing, like, do we send to surgeons, do we not? So that is good. It just kind of helps.
Now, it doesn't mean that those patients can just be left. Now, it doesn't
Right.
what we're saying is what we used to recommend is for all papillary lesions, just take the whole thing out. And then you don't have
Hmm.
to worry about it anymore. And you know what? If it's a patient that has a lifestyle where maybe they're not going to follow up, maybe that is the best thing for that patient, right?
Hmm.
But if you have a patient who's reliable and they can be watched and they're going to get regular mammograms to make sure that papillary lesion isn't growing, then that's fine.
Yeah,
They don't all need to, though, then those papillary lesions need to be taken out. So you don't have to refer all those patients to surgeons.
to
Are there
surgeons.
some that you think it's better for that particular patient? Go ahead. We're not saying
Right.
don't refer them, but we're
Yeah.
not going to make that recommendation on every single papillary lesion now.
Yeah, for sure. Okay, cool. Now I want to end on something that, I mean, I introduced you and there was a lot in there, right?
Okay?
You are such a fierce advocate for women in medicine. And like I
Yes.
said, you've personally helped me through stuff. So what what drives you to do that? And what is, while you're mentioning that there is a Trailblazer Award that people don't know about. So can you
Ah,
just explain?
okay. So I think um there's so much to pack in
I
here in
know.
under 3 minutes. And I'm not saying I mean, I love my female colleagues. I also mentor and I love many of my male colleagues. And most of my colleagues, 99% of my colleagues are fabulous, whether they're male or female, and they care about the patients and they care about treating their colleagues with dignity and respect. But remember, in the beginning, medicine was very paternalistic. I've used that word before.
Hmm.
When we think of all the and you can look at TV shows. Now TV shows, doctors are diverse. They're male, they're female, they're gay, they're straight, they're Asian, they're black. But when I was growing up, doctors were all white, male, middle-aged. All of them were. Every single one of them. And if that's and that actually begets a certain culture, right?
Right.
So you automatically think of a doctor as a middle-aged white male.
Hmm.
Um, and I'm just going to give you small things happen all the time.
Okay.
Microaggressions happen all the time.
Hmm.
I just saw an article about Jane Philpott, written by Andrew Coyne,
Hmm.
who's a very famous Globe and Mail writer, and I'm gonna say the name because he's very good, right? I love some of his articles. And when he wrote about Jane Philpott, who is a female physician, he called her Ms. Philpott in his article. That
Hmm.
happens all the time, right? I
Hmm.
remember going to conferences where my male colleagues would be in a lineup waiting for their room at a hotel, and they would all be because the hotel knew that there was a conference of pathologists going on, of physicians. They
Hmm.
called all my male colleagues Dr. Smith, Dr. Jones. And then when I came to the front of the line, I was Ms. Alakija.
Mm.
Why did you think I was not a
Yeah.
doctor?
Yeah.
Because I was female?
Right.
Those things happen all the time. And they're small things, but they make a big impact,
Right. Yeah.
right? They make a big impact on time. They make a big impact on patients.
On the person, on us, I think
Right.
we've come a long way, and yet we still have a long way to go. Like, we're touching on it very briefly. I almost think this is like an entire whole other episode, right?
Oh, it is.
Because
I mean,
100%.
just think Jane Philpott, who is one of the most important and famous female family doctors
Hmm.
in this country, and a famous, very good journalist still refers to her as Ms. Philpott.
Yeah.
Wow.
We've got a long way to go, and this is something that touches me personally and deeply. So I don't want to rush this. I want to dedicate the time to do it. But if a woman in medicine or anybody in medicine or not in medicine says, I want to do medicine, what would be your advice to them, especially as a woman?
Oh, make sure you're doing it because you really love it, first of all. And then when you're in medicine, don't pick a specialty or an area because you think you're going to get a job. Pick what you love.
Oh, I
Pick what
love
you love to
that.
do and don't limit yourself. Um, you know, female physicians can now be surgeons.
Hmm.
I remember when I went through medicine, you could, but boy, you were sure asking for a really rotten life,
Hmm.
right? Because it wasn't really accepted.
Yeah. Yeah. No, I love that. I was just talking to somebody this weekend. He's 19 and Nigerian, and his mom wants him to be a doctor, right? And really, when I talk to him, his heart is in, you know, computer science.
Then he
And
should
I,
do computer science. Mind you,
exactly,
with artificial intelligence and the way we use computers in medicine, there sure could be something for him to do in medicine.
for sure. But, I said to him, yeah, I see you. I know. Even when he talked about it, he smiled, the body language. And I said, that's where your heart is. He said, yeah, but she's my mom. And this is what she wants. So I just love that you said that. You've got to love it, because when the going gets tough, you have to remember, why did you do it?
And it is going to get tough.
It will.
It's even going to get tougher.
Yeah.
Our governments only have so much money, and frankly, medicine is a bottomless pit when it comes to financing it, right?
Mm,
When I talk about a tumor and all the different things I could do to analyze those cells, to personalize that tumor for that person and personalize the different kinds of medications that probably cost thousands and thousands of dollars,
hmm.
this can be a bottomless pit.
Yeah.
So
Yeah.
where, we somewhere society's going to have to decide um, what can be paid for and what can't. But right now, the way our Canada Health Act reads and the way we we expect um, medicine to be in Canada, we expect all patients to get limitless healthcare for a limited amount of money. No
Yeah.
politician, no bureaucrat in any health authority can do that. But where's the
Yeah.
crunch? The crunch happens to doctors and nurses. We are
Hmm.
supposed to deliver unlimited healthcare for a limited amount of money.
A little
And
amount of
so
money.
it comes on us,
Yeah,
right? The
for sure.
pressure is on us.
And we're all feeling it, and it's hard, and it's something that patients don't quite understand. Some do, but we want to, what I would say is, we want to give the best to them, right? But sometimes
Right.
our hands are tied.
Right.
Yeah. Yeah. I think we got through most things.
Okay.
Yeah. Do you have any final words or anything that you think that's important to get out there? Like I said, I really, really hope that I can get you back to talk about this equity and
Okay.
women in medicine, because I think that is so important. So
Absolutely.
at a later time, I'm going to come crawling back to you and say, please, please, please. But any final words on just on today's
Okay.
episode?
Well, I think I'm really happy that I had the time to chat with you. I think what patients don't realize is the humanity behind medicine.
Hmm.
Here you and I are a radiologist and a pathologist, and we're thought of as these very cold, clinical, very analytical specialties, right?
Hmm.
And anyone that knows you and me, they know we are both very warm people who absolutely love the patients. We're doing
Yeah.
this for the patients, and it's so important. Medicine has the two sides. You
Hmm.
have to be analytical. You have to have that knowledge, but you
Right.
also have to care about the patient. And I think that's kind of the takeaway is that radiologists and pathologists are working together to make sure that patients get the right diagnoses that's right for them.
No, I couldn't agree more. We are maybe not as visible as our colleagues, but boy, our role is big.
Yeah,
Right?
absolutely.
Yeah.
And you have a big heart, Ify. Thank you so
Oh,
much.
well, I thank you so much. You as well. I really thank you. Like you took the time, you left work, you went home, and you do so much. And like I said, I've experienced it firsthand, and I say it again and again because it really.
Sorry, that's my dog.
I know he's saying wrap it up, but yeah, I want to say it really means a lot, and I am so honored and blessed to know you, and I really do mean that from the bottom of my heart. So thank you so
Been an
much for doing
absolute
this.
pleasure, Ify. You have a wonderful day. And
Okay,
I'm
you
sure
too.
you and I will be talking to each other soon.
We absolutely will. Please note that the discussions and opinions shared in this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.